Hello class, this is Bonnie again. I'm going to be doing a recorded lecture for chapter 59, which is end of life care. This chapter is going to cover, it'll be week 3, and chapter 14 and 59's homework is together, if you notice that, on my IoT, and that homework is due on Monday, March 30th, if I am not mistaken. Just follow your student outline as to the due dates, because that's exactly what I'm going to continue to go by. So chapter 59, end of life care. What we have to remember though is, working with our clients at the end of their life, it is, and especially working with their families, it's a privilege and a challenge to a lot of us, but we have to remember it is a valuable learning experience, not only for us but for the clients and their family members. So nurses who dedicate their careers to end-of-life care must be compassionate and caring, and they have to understand their own feelings regarding life and death. So when we are caring for clients who are dying and their families, we have to listen to them and offer unconditional support. So remember, a positive end-of-life experience is impeded when the family, the client, and the nurse do not have the same expectations and goals. So on page 871 in your book, we talked about last week in chapter 14 about Kubler-Ross's stages of dying, and on page 871, there are other theories, her stages of dying are still generally accepted today, and these stages are denial and isolation. This isn't happening to me. Anger and rage. Why is this happening to me? Bargaining and developing awareness. I promise I will be a better person if only. Depression. I don't care anymore. Acceptance and peace. I'm ready for whatever happens. And detachment is withdrawal from life. These stages, as well as the other aspects of dying experiences, we talked about in chapter 14. So, what we do have to remember, though, is not all people go through the grief experience in exact same sequence or same way as someone else does. So, advanced directives. An advanced directive is an expression of the client's wishes about the kinds of treatment and care that he or she wants to receive if terminally ill or unable to make decisions about healthcare. So the most common advanced directives are the living will and the durable power of attorney for healthcare. So the living will is a document in which clients state the types of treatment they desire to receive or not to receive if a terminal situation arises, or if they are unable to make decisions or express their wishes. A durable power of attorney for healthcare designates a person of the client's choice to make these healthcare decisions should the client become incompetent. And then, of course, they also have an electronic form in a device that's called the eHealth key. But signed copies of advanced directives may be carried by the client and presented to the healthcare facility on admission. So different types of codes that we have. We have a DNR, which is do not resuscitate. DNR does not mean do not treat. It just means do not resuscitate. We have DNI, which is do not intubate. DNH, which is do not hospitalize. Full code, that is the CPR or cardiopulmonary resuscitation team, is to be called in the event of a cardiopulmonary arrest. Healthcare personnel do not determine whether a code should be called. So the thing that we have to remember is a copy of each person's living will should be readily available so that it can be taken to an acute care facility in an emergency. So, like I said, full code is that the CPR teams to be called at the event of a cardiopulmonary arrest, even though natural death is imminent. Ethics Committee. We have ethical dilemmas may occur when there's no advance directive or when there is an unclear advance directive. The Ethics Committee assists in making difficult client care decisions. The committee may become involved in situations involving donation of organs or tissues for transplants. And then the committee may also discuss types of medication to be used for symptom control. So organ, tissue, and donation. Advance directives or the client's driving license may indicate the wish to donate tissues or organs. And so, different types of tissues. It could be cornea, bone, skin, or the organs, kidney, heart, or lungs. But in most states, the next of kin or legal guardian gains custody of the body and must give permission for donation. So generally, a remaining spouse has the legal authority to consent to donation and must be included in all decision making. Most states have laws that require healthcare facilities to approach each family regarding donation of their loved one's organs or tissues if a person dies. So, it is important that the family knows about what your wishes are in relationship to tissue and organ donation. And most generally, nurses that participate in this portion of especially asking about donation of tissues or organs, they go through a special class. They are trained because they're trained so they know the correct questions to ask our client's family. So, and some of the common questions that families have regarding donation are, can they still have an open casket? Is there a cost to us? Will we know who receives the organs or tissues? And can we donate some organs or tissues but not all of them? So the key concept on page 873, the nurse who approaches a family for organ and tissue donation should see the family through this time of decision making and not transfer the responsibility to another nurse or healthcare provider unless absolutely necessary. Always remember, we have to be sensitive to the need of the family to have privacy to discuss the matter of donation. And then in some cases, there are special procedures that may be necessary to preserve the organs in sufficiently good condition to be transplanted successfully. So, healthcare facilities must approach each family regarding donation of their loved one's organs, even if the deceased had designated himself as an organ donor. True or false? That is true. Although they may designate themselves as an organ or tissue donor, the family gains custody of the body at death. And most states have a law it's often called the Uniform Anatomical Gift Act that requires healthcare facilities to approach each family regarding donation of their loved one's organs or tissues if a person dies or is expected to die very soon. Hospice. What is hospice? Hospice is a place or plan of care designed to assist the end-of-life client and family. It uses the principles of palliative care and provides respite care for the family. If the client's death has been anticipated and the client has chosen to die at home, a home care or hospice nurse will usually be assigned to the case. And sometimes, families need that respite care. They need time away, so to be admitted to a hospice program, though, the client must be certified as eligible by a medical practitioner, and the client's life expectancy usually cannot exceed about 6 months. Back to the basic needs as related to the death experience. Like I said, Maslow's hierarchy of needs. The dying client has the same needs as anyone else. So, most often we have to assist to meet even the most basic needs. So the goal is that the client and family will be able to work through stages of dying successfully. So nursing measures with regard to assisting and breathing include positioning of the client, keeping the nostrils clear, suctioning, administering supplemental oxygen, oxygen and airway. They can have Kussmaul breathing, which, that is often occurs in a person who is experiencing acidosis. This type of breathing is fast. It's usually greater than 20 breaths per minute. It's labored and deep. But Kussmaul breathing can rapidly become Cheyne-Stokes respiration as heart failure occurs. And those respirations are characterized by alternating periods of apnea and hyperpnea, which is rapid breathing. And as death approaches, the apneic periods gradually lengthen. Positioning. We want to turn our clients frequently. Frequent position changes do help prevent skin breakdown and usually do assist helping the client breathe more easily. Because if a client can be propped up into a partially sitting position or sitting upright, it, does help, with put undue pressure on the chest and the respiratory muscles and make it, because if they're bent over or slumped, that makes it for them harder to breathe. So we want to remember to always keep into consideration the positioning of our client. And sometimes clients can breathe easier or it's more comfortable if they're lying on their side. And also lying on their side can also, help with excess excretions too. So usually it's helpful and safer to have the head of the client elevated when they're on their back because collection of mucus and secretions may cause a death rattle as the client breathes. So key concept on page 875, their airway is of prime importance in caring for the dying client and helping to provide comfort. Remember, oxygen may or may not be ordered. Some clients request not to receive oxygen. Some clients do because it just makes them more comfortable and less anxious. We can also suction secretions, and that may be ordered, to assist in maintaining the airway. And then also with hydration and nutrition. If the client refuses to take anything by mouth, tube feeding or total parenteral nutrition or TPN is possible. Nausea and vomiting is quite common. The nurse can be helpful in providing supportive care. We can give antiemetics and we can provide mouth care. So with hydration and nutrition, a person can survive longer without food than they can without fluids. So sometimes clear cold liquids are preferred to hot liquids or solids. A lot of times clients like ice chips. So you just have to just take into consideration what your client prefers. So, like I say, most of the time, a lot of times clients do like to have ice chips. So because it does keep prevent their mouth from getting dry. And nausea, like I say, there are antiemetic medications that we can give. We can also put a cool damp cloth on their forehead. We can educate them on how to take slow deep breaths and lie on their right side, and also to eat dry foods. Sometimes, just plain old dry soda crackers will make someone's nausea a little bit better. But, we just have to take into consideration where our client is and what means that we can provide that would ease the nausea and vomiting. And of course, mouth care, we want to swab their mouth with mouthwash as often as necessary. We do have the prepared mouth swabs. A lot of organizations have those Just remember, don't let them bite down and bite off that little spongy part. Wouldn't be good. And elimination. Incontinence. Urinary incontinence is more common than bowel, so it is important to keep our clients clean and dry. And then, but we do remember some clients will have the inability to void. And if a client's abdomen becomes hardened, distended, or if the client complains of unusual abdominal pain, we do want to notify the physician. And constipation, some clients may not have a bowel movement for several days. It can be as a result of low food intake, a bowel disorder, or lack of stimulation, or lack of exercise. Think about it, some of the medications that we give, they have unwanted side effects, such as constipation from pain medications, especially opioids. We can give mild laxatives. We can also give stool softeners, which can be given routinely with opioids to prevent constipation. And then, of course, diarrhea is not uncommon in clients who are very ill. Diarrhea can also be a side effect of medications or can be the result of from lack of solid foods, can also be a result of a bowel obstruction, overuse of laxatives. It could also be related to the disease itself. So just remember, we want to make sure we keep their perineal area clean and dry. And hygiene. So we're going to bypass that one. Hygiene, bathing. If the client can't bathe themselves, we can assist. That is part of, we want to make sure they're clean and dry. Just make sure that, they, sometimes some clients are too weak to have a full bath, but we can give a partial bed bath. We need to assist them. We need to make sure their bedding is clean and dry. And because it does help them make them feel more comfortable. And they're cleaning their eyes, their eye care. We want to clean their eyes and keep them moist by gently wiping them with gauze pads, moistened in normal saline. And remember, we go from inner to outer. Hey there, Dan. And then hair care. Sometimes, if they're really ill, they don't pay much attention to their hair. But if they have long hair, you can put it in a braid. There's also shampoo caps or dry shampoos that we can use. But just as nurses, we just want to remember to make our client feel as well groomed as possible. And then, of course, odor control. Always make sure you can help control those unwanted odors in a client's room. We want to keep their dressings clean, dry, and intact. We want to empty their drainage bags. And sometimes you can use a small amount of wintergreen oil on a gauze pads because it is an effective deodorizer if you don't have anything else available. Other times I've heard they use like vanilla on a cotton ball and just put it in a little med cup and sudden or out of sequence here, but I'm going to talk about the signs of approaching death just really quick. So loss of control over bladder and bowel, intake of food and drink will diminish, the extremities will feel colder to the touch, the person experiences increases in fatigue and difficulty walking, occasionally they'll have restlessness, the recognition of familiar people, places, or objects decrease, and the visions of people or things that do not exist may occur. And dry mouth and accumulation of thick secretions in the back of the throat often occur. Noisy breathing is common. Cheyne-Stokes respirations at the point of death, breathing, heartbeat, and pulse stop entirely. The person is unresponsive to shaking or shouting. The person does not respond to painful stimuli. The eyelids may be open or closed, and the pupils are dilated and fixed in one direction, and loss of bladder and bowel control occurs. So, care of the family. We want to encourage the family to express their emotions, take comfort measures to ease the client's pain, continue to communicate with the person, and reassure their loved one. Explain the physical and emotional stages associated with dying. Family respite. This is on page 878. Because sometimes it is important for family members to remember that they need personal rest and refreshment just as much as the client does. A lot of facilities will have a lounge or a chapel where family members can go sit at and be alone. But you do want to encourage your family members to go out and make sure they eat and get rest for themselves, and assure them that you will call them immediately should any change occur. Some family members refuse to leave because they want to be there. That is their choice. But always just, reassure them that you will call them, and make sure that they get rest and that they are eating as well. And the role of hope. Dying individuals may cling to hope and not give up until the very end when they finally reach acceptance or withdrawal. Families may cling to the hope that an unexpected recovery may occur. But, just as nurses, we have to remember, do not give false hope. The role of our, as being a nurse and other healthcare professionals, we have to be honest with our clients and support them in their own way of coping. But I'll just, please remember, do not give them false hope. You guys on page 879 is with the signs of approaching death is remember that the dying process proceeds from the distal portions of the body inward. Therefore, the legs and the arms lose sensation and the ability to move before internal organs cease to function. So sometimes peripheral circulation diminishes first, and then stops, and the client will often experience diaphoresis or elevated temperature, and then the body cools. We can provide light coverings, we can do warm blankets, but falling senses, remember, research has shown hearing is the last sense that is lost. Most clients can hear until the final moment, so speak distinctly and do not whisper or talk about the client. Talk to the client. Even if they are unable to answer you, you need to talk to them. Try not to leave them alone, as the dying client is likely to feel a sense of increasing darkness as vision begins to fail and may turn toward a window or other source of light. And care of following the death of a client. Pronouncement of death. The formal pronouncement of death varies slightly among states and provinces. Caring for the family. Care of the family now becomes the nurse's major focus. And we want to help them to make the transition to bereavement. The family, depending on culture, the family can assist with the care of the body after death in the healthcare facility or in their home. Some cultures require this care to be performed by the family. And like I said, clinical death occurs when respiration and heartbeat both stop. And for the client who is a DNI, note the exact time when respiration stops. Usually that's first. And then the exact time when the heart stops beating. Notify your healthcare provider or other primary care providers. Biological death is defined as the irreversible cessation of heart and lung functioning. So, then brain death or cerebral death is irreversible cessation of total brain function, including the brainstem as determined by clinical examination, and EEG determination combined with other criteria to pronounce biological death. There are two exceptions to the usual criteria for biological death, and they are hypothermic condition and central nervous system depression secondary to drug overdose. These situations require additional studies, and the ethics committee may be involved in some determinations of brain death and procedures to follow. So, like I said, pronouncement. In most states, a healthcare provider must make the pronouncement of death occurring within a healthcare facility. In the event of an accident, suicide, or homicide, death may be pronounced by the coroner. The coroner is called and pronounces the death, and then they determine who will manage the scene, which is then considered a crime scene. So, a lot of times if it's a case of a sudden or suspicious death, it is the coroner who is called and pronounces, and then that scene is then considered a crime scene. And for the postmortem exam, if it is desirable or required by law, in some cases, and in the event of a sudden, unexpected death, and certainly with any suspicious of foul play, a postmortem examination is required, and this is known as a coroner's case, and no consent is required for that. So, family decisions. When a loved one dies, the family may be required to make three major decisions involving the performance of an autopsy, donation of organs or tissues, and choice of funeral home or crematorium. Other things is, they have to make a decision regarding memorial service or other recognition of the client's life, posting of death notices in the newspaper or online, contacting special agencies such as the VA for a military funeral. But what we do have to be aware of as nurses is that in some cultures, burial must occur within 24 hours of death, and in some cultures, cremation is required or forbidden. So, after all of this, we have to take care of ourselves. Remember the feelings of the nurse. We have to remember to take care of ourselves, because one of the greatest challenges facing the nurse is providing care for a dying person. Your colleagues can be an informal help by allowing time for grieving. Many healthcare facilities do have meetings following the death of an individual. But remember, team members can give each other mutual support. And expressing sadness to coworkers and to the person's family is also appropriate. So, always remember, there is no one who is going to take care of yourself unless you take care of yourself. So, this can be a very trying time for nurses, especially if they become very close to their clients. This can be devastating to some nurses, so just always, always remember, take care of yourself. This is chapter 59, and like I said, chapter 14 and 59 homework is together on my IoT. If you guys have any questions on this chapter or on the homework, please don't hesitate to give me, send me a quick email, and I'll see what, I'll get back to you guys as quick as I can. Also, just a reminder that on Monday, your first quiz for Nursing 401 will be open and online at around 8 a.m. And I will leave that open until 3 o'clock. And your first quiz will be over chapters 103 in the basic nursing book and ATI Chapter 1. And if you have any further questions, just shoot me an email. Have a great weekend, guys. Bye.